Welcome back to NeuraXis Care and Research Center. Let's continue first part with Dr. Albert Fenoy.
Global assessment of function less than 45, ages 22 to 70. Patients have had to have recurrent episodes or at least a long chronic episode of depression and failed to respond to multiple trials of antidepressants, psychotherapy, as well as ECT. So these patients are clearly treatment resistant. They have tried everything and have failed. When we do the surgery, we implant our electrodes in an IPG in the single setting. We follow them for 52 weeks. The first 10 patients we used initially after surgery, we had 4 weeks of an off period. It's kind of a single blind sham stimulation period. This is because in other work that was modeled in Germany, where it has also done the same type of target, when we turn on the stimulation right after surgery, we can't really, there's an insertional effect, just like we saw insertional effects in Parkinson's disease and dystonia. And so when we're trying to find the actual improvement from stimulation, if we turn it on right away, we don't know, we kind of try to, it's very ambiguous with it, whether it's due to insertion or stimulation. So by having it off for a period of time before turning it on, we can actually see that the patient is getting better from stimulation. And so we've increased the 4-week initial off period is what we have for our first 10 patients. We now have for 12 weeks or 3 months. So the patient after surgery does not have them on, they're kind of blinded to the results. So we can clearly see an improvement of their depression, and then it gets worse over time before we turn on their stimulation. We don't adjust medications for the first 6 months. So during surgery, this is an axial picture of what the fiber tract would look like. We intercept the target area is just anterior to the red nucleus. It's based on diffusion tractography. During stimulation, the patient's awake, and we can really ask them to describe their feelings or energy level. Patients are typically in very monotonic states. They're not very conversationalist. But with stimulation, you can see a clear improvement of their ability to look around the room and want to engage in behavior. They encourage the spontaneous dialogues increase. They basically can even start smiling or are more interactive with myself or whoever is interviewing them. One of the key things that we look for as a side effect is diplopia, because the target area is very close to the exits of the oculomotor nerves, which transit through the ventral tegmental area. So this is basically, the target is at the efferent fibers of the ventral tegmental area. And so if I have too high of stimulation, if the threshold of diplopia is too low, we may have to move our target. So that's why we put in multiple microelectrodes and macrostimulate, just like we do for tremor or Parkinson's disease. So this just shows that what the picture of the fiber tract would look like after modeling in the sagittal view, axial, coronal, and in an oblique view, showing that we have clear representation of our fiber tracts from the brainstem on up towards the prefrontal cortex, specifically orbitofrontal cortex. What we're targeting is the superior lateral branch of the medial forebrain bundle, as it courses superiorly and anteriorly, as opposed to the inferior branch that crosses through the hypothalamus. So it's another representation of how the fibers may look like. You can see they're going clearly to the orbital frontal cortex. This is a picture of our first patient that was over 8 years ago. So we've written many papers. This is our publication of our first 4 patients at 26 weeks. This is our first 6 patients at 52 weeks. This was a scientific review that just showed that basically medial forebrain bundle is a strategy to modulate the reward system and to manage treatment-resistant depression. And this last paper just came out earlier this year in molecular psychiatry, showing that our first 10 patients at 52 weeks had a sustained improvement that is consistently good through 5 years. So it's a durable type of modulation. So here's more of the nuts and bolts of our results. So this is a picture of our first 10 patients that was published in the Molecular Psychiatry Journal. And on baseline and on the x-axis, you see the first 4 weeks. I'm trying to show my arrow here. The first 4 weeks the patient is off after surgery. On the y-axis is the MADRS score, or depression rating. And so initially all patients are depressed, but we can see after surgery, for the first 4 weeks, the patients are off, and then there's initiations at 4 weeks after surgery in the first cohort of 10 patients. But we can clearly see that there is an extreme insertional effect. So even though stimulation is not being turned on for the first 4 weeks, there is a large decrease in depression score, and that's pretty significant. And the red dotted line is the average. Some patients have a profound insertional effect, some patients don't. But the bottom line is that most patients have some type of an effect. So The reason for wanting to increase our sham stimulation phase for 3 months is because there is an insertional effect. You'd see that just like with tremor or Parkinson's disease. But in psychiatric disease, it's a lot more difficult to assess. And so we have to really make sure that the stimulation's off. If we're ever going to get this FDA approved, we have to show clear effective stimulation from placebo. So this is another representation in a different way of the same information but extended longer. This is over the first 52 weeks for our first 10 patients. Instead of showing a MADRS score, this is the percentage response of MADRS. And so again, here this is the first 4 weeks of sham stimulation, and then we turn it on. This is a significant antidepressant effect. But after the first week after turning the stimulation on, there's even a larger increase in effect. And at 2 weeks, there's even a greater improvement of the response. Response criteria in depression is a greater than 50% improvement of your MADRS score from baseline. And that's considered at a 1 year interval where we consider a patient is a responder or not. And at 1 year, the mean response rate was pretty great. One of our patients at 6 weeks after surgery dropped out, didn't want to be part of it anymore, so we had 9 patients. And at 52 weeks, we had 6 out of 9 patients were responders, so a 66% response rate. But the mean response rate at 52 weeks was highly significant, 63% improvement of MADRS scores. So if we look at all of our electrodes, plotted against standard atlas of Cortis, they all kind of appear in very similar location at the supralateral branch. This is part of the same publication.